Okay, looking at the cervicothoracic area, the two treatment techniques we really have to consider here is a traction technique and also a technique for the first rib. We're going to look at these specifically because in the last tape we actually looked at some of the more mobilizing techniques. And I'll just reprise these quickly for you now, just to refresh your memory, and then we'll move on to the newer techniques. So, for the cervicothoracic region, we need to have the patient holding onto the back of their neck, there, and we'll support underneath the arms and across. The movements we'll be doing will be very small amplitude movements. There is not much displacement required to test the movements at these joints. And we can do combined testing. Again, we can position test this initially if we want to, and then come in and specifically test a particular movement. So if this was an FRSL, I would extend, right rotate, right side bend. If it was an ERSL, then I would flex, right rotate, right side bend. Or if I didn't feel like position testing, then I could simply come in and check all of the quadrants, flexion and extension through these levels. Just relax for me. There. But very small displacements of the arms. Treatments. Last time we looked at basically coming in and mobilizing as we fixed. So that would be flexion, right rotation, right side bending, and extension, rotation, right side bending. We can do the same as we did in the rest of the thoracic spine though, and basically mobilize these with a direct push on the posterior transverse process. So for a ERSL, we could put them into this position, the corrected position, basically come onto that transverse process and push it up and forwards. If it was an FRSL, we can't do that the same way because in prone the scapulae come together and limit this. But we can basically come in, put them into the corrected position, come onto that posterior transverse process and push that up to bring the right one down into extension. Or in this position, we could come onto the inferior articular process and push that up onto the superior, which is relatively bringing the superior facet of the zygapophyseal joint into its extended down position. So we have these techniques available to us.